Welcome to Cure Expert Connections on Neuroendocrine Tumors. I'm Dr. Robert Ramirez. I am a medical oncologist at Ochsner Medical Center in New Orleans, and I am the medical oncologist at the LSU and Ochsner Neuroendocrine Clinic in Kenner, Louisiana. Today we're going to discuss neuroendocrine tumors, and we're going to be joined by two of our patients who are going to share their stories. So neuroendocrine tumors are somewhat uncommon. We're seeing more and more of these things, and we'll talk more about some of the reasons for this. They arise from the diffuse neuroendocrine system and can arise actually from any organ in the body. Majority of times, these things start out in the abdomen, sometimes in the most commonly in the small intestine, but we can see this in the colon and also pancreas. But we also can see this above the diaphragm. We see this actually up to 30% of the time start out in the lung. And they tend to be slow growing, but they can range on degrees of aggressiveness from very, very indolent tumors all the way to very, very aggressive and then anywhere in between. So treatment for these sorts of tumors depends on where you fall on that spectrum. Now, patients can come in with a variety of symptoms depending on, one, where their tumor starts, and then two, if there are any associated hormonal syndromes. And depending on where things start, it can be a very slow go as far as the first onset of symptoms to an actual diagnosis. And some people will say sometimes up to 10 years between your first recognition of symptoms till the time someone gets diagnosed. The diagnosis of neuroendocrine tumors varies. It depends on where things are located at, where this primary tumor starts, and the associated hormone production. For instance, many times these things will start in the small intestine and cause problems due to excess hormone secretion, and patients may complain of vague abdominal complaints, diarrhea, flushing, sometimes abdominal pain, and this can go on for a very, very long time. Sometimes they seek treatment with a GI doctor who does the standard treatment, the standard diagnostic tests, including a colonoscopy. Sometimes they get a scan, sometimes not. Sometimes what I commonly see is patients get labeled as irritable bowel syndrome. I saw a patient just earlier this week. He was labeled as Crohn's disease and treated for such for many years until somebody actually gets a tissue diagnosis. Now, those are the tumors that start out in the abdomen with these complaints. Sometimes they're asymptomatic. Sometimes someone does a scan for another purpose and says, oh, there's something there in the liver or something in the small intestine. What I commonly see in patients that have tumors start out in the lungs is a little bit different. Sometimes they're asymptomatic and get a scan for another reason, and they say, oh, you've got a nodule or a mass in the lung. But things can vary. Patients that have tumors that start out in the lungs can have cough, can cough up blood sometimes. It's a relatively common presentation, shortness of breath, wheezing. Many times patients get misdiagnosed with asthma and put on asthma medication, and they're on this for years and years, and then someone finally does a scan and says, oh, you've got something there. So the diagnosis can vary from the initial symptom to an actual correct diagnosis. Well, so when we look at tumors underneath the microscope, we categorize them in two different ways. One, we look at the differentiation status. Well, three different ways. One, we look at the differentiation status, and that tells us how closely this tumor resembles the site of origin. it goes from well-differentiated, moderately differentiated, poorly differentiated, and sometimes even undifferentiated. Your well-differentiateds tend to resemble your tumor of origin, your site of origin. Your poorly differentiateds don't. And based on that, we can sort of say where you're at on the spectrum of aggressiveness. So the well-differentiateds tend to be more indolent than your moderately differentiateds, than your poorly differentiated. Now, the other thing that we use is Mitotic Index. That's the number of mitoses that when the pathologist looks at this underneath the microscope, it tells us how these cells are dividing, and then something called the Ki-67, which is essentially a percent of those dividing cells. So being a percent goes anywhere from less than 1% all the way to 100%, with 100% being very, very fast growing, 1% being more on the slow growing side.